Welcome to the Health Innovation Summit. The session will start in 5 minutes. Please take your seats and silence your electronic devices.
Is the
Welcome to the Health Innovation Summit. The session is about to begin. Please take your seats and silence your electronic devices.
No matter how hard I try, you keep pushing me aside and I can't break through. There's no talking to you. It's so sad that you're leaving. It takes time to believe it. But after all is said and done, you're gonna be the only one. Oh, do you believe in life after
Cell
life?
therapy to robotic surgery, we're leading the way in healthcare, harnessing our strength in both medtech and innovative medicine to drive progress across the full spectrum of healthcare solutions. We're building a world where complex diseases are prevented, treated, and cured, and where solutions are personal. Every day, we profoundly impact health for humanity. We are Johnson & Johnson.
For more than 100 years, Novo Nordisk has been driving change. What have we learned? Helping to improve lives must go hand in hand with improving health and well-being. That people are more than their disease. That's why we have spent more than a century developing treatments to help people live lives less limited by their disease. A century of pioneering scientific breakthroughs in key areas. Today, we lead the way with transformational initiatives aimed at creating better treatments and a better world. Like you, we do it for the people who are living with, thriving with, and not being held back by disease. They are why we are investing in new, innovative medicines, why we are continuously expanding our offerings, why we are working toward an even brighter future. It's why, through the Novo Nordisk Foundation, we support scientific, humanitarian, and social programs. We are, and will always be, committed to driving change, to fight for the people living with, thriving with, not held back by disease. We call them the greats, because their disease doesn't define them. So what will? Novo Nordisk, driving change. Learn more about how Novo Nordisk continues to drive change by scanning these QR codes.
Now, please welcome back to the stage NCQA Senior Communications Advisor, Andy Reynolds.
Hello and welcome back. We have been asked by several people, how or where can we read more or learn more about things that we are finding out about at the summit? I have two resources to recommend. One is the NCQA blog at ncqa.org/blog. That is written as an easy on-ramp to many complicated quality topics. Similarly, the NCQA podcast called Quality Matters, available wherever you get your podcast. That is another channel where we are very careful to make things easy to understand. We had just backstage a few minutes ago a little reunion. Two recent podcast guests are on the next panel. And in addition, Laura McCrary of Kanza from the previous panel has also been on the podcast recently. So NCQA blog, NCQA podcast, great resources to learn more. Speaking of helping those of us who were English majors learn about technology, NCQA's Chief Technology Officer, Ed Yurcisin, has a real gift for that. About a year ago, he made the rounds to various departments at our company, explaining in incredibly accessible, clear ways what digital measurement means. And he is a master of metaphor. I still remember references to baseball that he worked into his explanation, references to his son's high school curriculum. Ed's quite a guy. I will let him introduce the panelists, but please welcome NCQA Chief Technology Officer Ed Yurcisin and Ed's panel.
Great, thank you. So up on the screen, we've got our learning objectives. We also have a slide about some of our conflicts and the things that they just want us to talk about. So thank you for joining us. Happy Halloween. And you know, I realize our Hindu colleagues have actually sacrificed more than just Halloween. They're here during Diwali, so thank you for participating. We have a fantastic panel today, and so I think you're really going to learn a lot about digital quality and the journey that these organizations are going through. Khanh.
Hi everyone, Nguyen, I'm the CEO of Cozeva. Cozeva is a value-based care enablement platform. It's also a real-time population health solution, helping payers, providers, and different stakeholders across the ecosystem drive value-based care. So we actually focus on all 5 components of the quintuple aim. This is health equity, quality, costs, care experience, et cetera. Seeing some familiar faces in the audience. Hi, Amol. So Cozeva, we've been in the digital quality journey for over a decade now, and we're NCQA certified HEDIS engine, we're NCQA validated data stream, we're ONC HIT. I promise I'll finish all the acronyms. So we've done a lot in this space and have been so grateful in learning and collaborating with NCQA. We participate in the early adopter program with DCS, and we also were part of the original members of the DQIC, the Digital Quality Implementers Community. And then more recently, we've been working with NCQA to test DCS and CQL with real-world data.
And Rebecca.
Hi everyone, I'm Rebecca Jacobson, physician informaticist. I'm CEO and co-founder of Astrata. Astrata is a digital quality company. We use FHIR analytics and NLP to help payers to move to a type of quality measurement that we think is more proactive, prospective, and population-based. We have also been working with the NCQA for some time as one of the original beta testers of the digital measures as part of this early adopter program for DCS, and in other ways, such as participating with the NLP working group, et cetera. And it's been a real pleasure and also, I think, a real learning experience for us and for the customers that work with us.
And Emily.
Hi, I'm Emily Kipping. I'm AVP of Provider Analytics at Blue Health Intelligence. BHI is a analytics firm. Primarily, we work with the Blue Cross Blue Shield plans. And in my role, we leverage a lot of the NCQA measures in support of provider benchmarking, provider performance, and network insights. And we also do a lot of work on like real-world evidence, working with other stakeholders in the health system. Similar to the other panelists, we're also an early adopter of the digital measures. And similarly, we've also learned a lot through that process and looking forward to having a great conversation today.
Great. And Alan.
Hi everyone, I'm Alan Kua. I'm the Chief Innovation and Technology Officer at Ingenia Health. And thanks to NCQA for having me today and with this distinguished group of panelists. About me, I am a software engineer with 25 years of experience in delivering enterprise applications and data analytics. And if you haven't heard about Ingenia Health yet, we are a data analytics company. We work with large healthcare payers, and we deliver our solutions to over 2 million lives out in the industry. And also, we have been HEDIS certified vendor since 2011. And since that, we have been submitting official results on behalf of our clients. And also, as Emily and the group, we have been collaborating with NCQA very earlier. I remember back in 2016, we were one of the first creating also the digital measures for depression screening, I think. And now we are also working with digital content measures. So thank you for the opportunity.
Great. So this is a fantastic panel, and I think you're going to learn a lot about digital transformation and the lessons learned from these different organizations. So, Khanh, starting, tell us a little bit about your digital quality journey and where you might have had challenges and successes.
Yeah, and I apologize, I'm gonna have to refer to my notes because there's been a lot of learnings. But I would say that the move towards digital is really for the vision of reducing administrative burden while increasing accuracy and fairness of reporting. So that's the vision. And while it may seem theoretical, I think we're all trying to make great strides towards that. But there have been, I think, some significant learnings. So I'll touch upon 3 learnings, because I think the panelists will also have a lot to say. So I think for us, implementing CQL measures in production applications has been challenging. To be prepared, I think vendors really need to rethink how you aggregate data and perform clinical reasoning operations on them. In one of our recent testing of the digital content services with real-life data, we saw a 40% discrepancy in the measure reporting. And that's just, we saw an average of 40% discrepancies across a handful of measures. So I think there's going to be a lot of work, significant work still required as an industry and as more and more vendors, partners jump in and participate and share the learnings. The other thing I'll mention is the experience and in-depth understanding of clinical data is absolutely foundational. So we've all had the experience of leveraging administrative and claims data for reporting. And I think when you test beyond simulated data and you're testing with real world data and having that in-depth understanding of clinical data and all the variations that exist, I think is really, really key.
Great.
So those are my few learnings so far.
And Emily, at Blue Health, tell us a little bit about what you found with your digital transition.
Sure, so I think we're a little earlier on in the process. I think kind of similarly, like what the approach we're taking is kind of testing small, making sure that, as we go through this transformation, we're kind of breaking it down into each of the component pieces. So like we know with the digital measures, you need to start with data in FHIR format, whether it's claims or clinical data. So we've been trying to take a kind of step-by-step approach, testing at every step, running real data through it. We don't really believe that kind of the synthetic or test data is enough. And we're starting to see some results. I think kind of similarly, I think there's a lot of work to do, and I think that the goal for us is really reduce the amount of time we're spending authoring and creating measurement and spend a lot more time actually doing something about the trends you see. So we're really excited about where we're going, and just sort of making sure we're breaking it down and testing it each step of the way is really important to us.
Great. And Rebecca, I think you've got lots of stories and lots of learnings. Can you explain a few of them?
Sure. I really echo what the other panelists said. I'll say that I think using these measures from the beginning and actually computing measures from the beginning and continuously is really an essential part of this journey. I sometimes, talk with people who feel like I need to go off into a corner for 2 years and work on my data, but no, you really do want to be computing the measures right from the beginning. So that would be one lesson. I think the other thing, and doing it at scale and working up, just as Emily said, bit by bit. First you're going to get a 0 result, and then you're going to get your first non-zero result. Cheers will go up when you get your first non-zero result. And then you're going to get your first non-zero result that you can explain and you really understand and you know why it's different. And it's going to just continue to develop like that. So you really need to have this kind of mentality, I think, this iterative mentality of just continuing to solve problems and continuing.
Is it a data quality challenge, or where?
I think there are data quality challenges, but I think that the mapping is not necessarily obvious as to how to do it. And there's a lot of learning that goes on in that process. Exactly as Khanh said, knowing the data, really knowing what you need to be mapping to what. Takes a little bit of time, but the good news is that once you do it across a couple of measures, the resources you're going to see them over and over and over again. So
it starts to snowball a little bit.
It really does. It starts to snowball. So those would be some things. I'll also add that I think that one of our learnings seems to be something that I learn continuously, is that it's when you're developing standards-based software, like we all are, it really requires a community, because the people who have all the data need to be telling the people with the computable standards what's going on, and it takes collaboration. And I think that's one thing in that early adopter program that I think we can build on.
That's fantastic. And Alan, a little bit about your journey at Ingenia.
Oh, yes. I think we learned a lot. I can start by just simply defining digital content services, right? Because it could mean a lot, but I think we can summarize that as it is a HEDIS calculation engine, but I think the most important is the vision, right? Because for me, DCS is like an accelerator for everybody else to build digital measures, right? And we start to see a lot of value in this because measures are delivered as a service. So we just download the CQL. This is so important because we hear a lot of FHIR and CQL, right? And FHIR, in this case, the data clinical model in which the DCS is based on, and the CQL is the measure definition. So now when we move from measurement year 2023 to then 2024, and we just noticed that the update was download the CQL and the engine will continue work. So that's amazing in terms of acceleration of that heavy lifting that we have to do as HEDIS vendor or you and your own organization developing and programming code in the measure. So now you just download and continue running. But also that has several challenges, right, as you have mentioned, and is that even though this is FHIR has, we learn and we continue adapting to that, is the FHIR is like the data quality language or data model, right? But then you have multiple like flavors of FHIRs, right? When we hear also for US Core and we hear for Keren Blue Button on all of that. So DCS relies on a new implementation guide or profile that is called the HEDIS Core. So I think those three building blocks are so important when you start this journey in digital measures. It's okay, perfect. These are the building blocks, and we need to prepare our data and collect the data to be ready for digital measures.
Okay. And Rebecca, we were talking a little bit about readiness. Do you think Astrata was better prepared because of your involvement with ECDS measures?
You know, I'm not sure. I think partly we started the journey digitally. You know, as a company, when we spun out in 21, was like, not doing traditional. We're just starting with digital.
Okay.
So that might have been part of it.
You know, and part of the challenge is really understanding all these acronyms. So,
Yep. True.
What are ECDS measures? They're part of the HEDIS portfolio, but ECDS is really a set of rules defining where the data is coming from. The data could be coming from case management systems, from registries, and from EHRs. One of the differences with digital HEDIS and DCS is that we are requiring FHIR. It is a FHIR data model. We're also, part of this transition from an NCQA standpoint is HEDIS measures have historically been very claims or administrative based. And we're moving to a world where we're introducing and integrating in more clinical data, and we call it data our data. And we're moving to a new world where data is more interchangeable and more ubiquitous, not dependent upon its source of origin. So, Alan, about your digital readiness. So, how would you even define digital readiness?
Yeah, I think it's a lot of, so we are working in general, NCQA and the industry is working on the DCS as the magic technology piece, right? But I think for the readiness, data quality is so important. From your point, I think I remember one example that we were discussing at some point is how to correctly map the data. So the data needs to be now more than ever compliant with what the measure is expecting. So far, this vendor or anybody that was doing calculation just solved the problem following the guidelines from NCQA, and then you coded and you had the expected outcome. Now, I think it's more strict, right? It's strict because, for example, a mammogram, instead of being a procedure, needs to be an observation, I think. And also, I remember that there are other challenges in case you have providers submitting multiple claims for the same day, same encounter. Now you need to merge those and consolidate before you process on DCS. So data quality, data challenges need to be solved before using the engine. So that's so important. Yeah, because the technology, FHIR and CQL won't solve those problems. So right now, the readiness, part of the readiness, continue working on that data quality, create indicators or start doing, okay, how many issues do we have? And now we need to work before that.
That's great.
Can I say something on that one too?
Absolutely.
I wanted to add something. That was such a great answer, kind of complementary but rather different, and that is, you know, I spend a lot of time talking to sort of health plan quality leaders about readiness, et cetera, and I think there's a kind of an organizational readiness too.
Expand on that.
Yeah. I can tell you this, that the way I try to get at it when I talk to people is to ask two questions. I ask, you know, have you gone and talked to your CIO or chief analytics officer or chief data, whoever it is, especially the person who is involved in like interoperability efforts, maybe they were involved with the FHIR, you know, server, et cetera. And the answer to that is very revealing. And then the other question is, you know, have you gone to your senior leadership team and explained why this is so important for quality measurement?
That's great.
Yeah, can I double click on that and just actually ask the audience, and we're totally going off script here. Show of hands on who knows the difference between, I know you gave the answer, between ECDS and digital quality. I just have two questions for the audience.
There is one.
3 or 4.
All right.
Okay, so then of the ones that know the difference, how many feel like their organization is embarking or will be ready to start the journey for digital quality? Start. We have one start, two, and then one on the back there. So, I mean, I think to what we're saying, readiness, going back to Alan's point, so eloquently stated, to me, it's data readiness. And then it's just organizational and leadership buy-in and alignment.
And it's having FHIR in your data pipelines.
Right.
It is.
And that, you know, that's hasn't been ubiquitous across the industry. So, Rebecca, what challenges are you seeing with, you know, with Astrata and its clients that, from a digital readiness standpoint, and what are you looking for to understand that you have successful milestones and you're making progress?
Yeah. Well, I think one thing, and I think this is not just our customers, I think this is just generally true. I think it's what you said. You know, there's just a lack of experience, you know, and expertise. It just hasn't developed yet. It's coming. You know, the groups that have participated in the interoperability requirements, they know what these things are, but quality really is much harder. It's much more complex. So that's one issue. I would say that, you know, one of the things that we developed, and I'm going to talk about two particular customers in a minute, but one of the things that we developed, and you can find it on our website, is kind of like a digital quality maturity model. Like, how do you actually move from kind of, you know, couch to 5K, if you will, you know, and start just with the simplest things, which really have to do with data, and start to expand from there. I will say that, I want to call out two, if I may.
Absolutely.
Two actual customers who gave me permission to talk about them, who I think are really moving along quite quickly now. One is AmeriHealth Caritas. I know that Vanya will be here tomorrow if you want to find her. And I think one of the things that they did, as we were starting to talk about this organizational readiness, is that they really have a very big picture of how they're going to use FHIR in their organization, and it's not a bunch of silos, actually. I think that's really critical. And then from the other customer I want to mention is UPMC. I think with UPMC, who we've been working with for a long time now, I think that there's a real deep understanding of the degree of change management that is going to be required for digital quality. And I don't think we should undersell that. This is a big transformation, and a lot of downstream things in a health plan, a real health plan, will have to change.
And Emily, what's your experience with readiness?
I think for BHI, I think readiness, we're a sort of smaller, fairly niche company. So for us, I think readiness is really about sort of thinking about what problems are we trying to solve, and then how, where are there kind of bets we can place on how these, the transition to digital quality measures can get us quicker, better, faster, cheaper. I think that as I think about it, sort of the transition here, it's not that dissimilar to, a couple decades ago, moving from like paper to EMRs. Like that's a huge, huge amount of learning. I remember one of my first jobs was scanning in paper records in my parents' doctor's office. And so I think, as the community, as payers, as providers, as all of us come together and figure out how we can make things both interoperable, but from a quality perspective that we're able to accurately measure, that people trust the measurement, that the outcomes represent what actually happened. I think that each organization is going to have their own version of readiness depending on the types of problems they're trying to solve. And at the same time, there are standards that we have to meet, and there are sort of regulations that are going to kind of push us in one direction or other.
Yeah, and we're definitely leveraging the standards. So we're leveraging the FHIR standards and the CMS mandates and so forth. And with DCS and Digital HEDIS, we now have computable standards. That's part of our objective from NCQA standpoint is DCS creates standards around the computations of these measures. So when we start looking at indicators of where organizations are, Khanh, what's been your experience with that?
It's been interesting as we look across, within organization, where we've been on the digital journey for a long time and been one of the early adopters and trying to lean in. But I do see, even though the show of hands in here was very minimal, I actually do see some remarkable progress across the nation. One I'd like to just double click on is what's happening in California. In California, Cover California is one of the purchasers, and they represent the marketplace for Californians. And what they are embarking on is a journey to standardize clinical data reporting for quality measures. And we're pretty excited because they're intending to award the RFP in this work to Cozeva and the Integrated Healthcare Association. And I think this work is actually going to go deep and drive and understand the data elements that live out there across all the different health plans and the provider organizations that feed the data into the health plans. But really the objective is to push what NCQA has been pushing, which is moving towards digital, but also with the emphasis on really to deliver better health outcomes. That's really the end goal here. So there is, there's going to be a lot of learnings on what does this transition to ECDS look like. And we're really hoping that the learnings from this initiative will not only help inform NCQA, but also CMS QRS. So that's just the first phase, right? We're talking about just moving everything to ECDS. Along the way, there will be some movement towards FHIR, CQL, digital quality. But I do see that as a huge example of progress when you have a purchaser getting alignment across health plans, all contracted health plans in California, and the alignment across the provider network. I think that's a huge demonstration.
I agree.
That's great. Yeah, that's really a lot of progress. And, you know, Alan, when you're working with organizations, can you talk a little bit about kind of the steps or the milestones that you're trying to achieve?
Sure. Yeah, I think the first important thing is to have the leadership support to understanding what is happening in the industry. Because I think we have been talking about this digital measure or digital transformation, but now we are seeing specific dates. So now there is the ONC IT, the draft for FHIR adoption. There are a lot of incentives for the HIEs to start using FHIR. So the timeline is moving. And now we have DCS, so we have an engine that runs digital quality measures. So people need to get trained on that and start learning more. So this digital quality conference is great because we start learning more and more. So that's the first part. So we look that organizations start to talk more about FHIR and what it means. Obviously, you don't need to work the technical details, but you need to be aware of how these building blocks work. I think the second part that we encourage and we see for organizations is so important to integrate how do you expect to receive the data. So start playing with, even I was in a previous session, the California government doing the savings for just data sharing, right? I think saving over $500,000 just for sharing specific data for BCS, colorectal cancer screening, CCS, even using traditional standards. So imagine the impact on savings and time by using FHIR. So you need to start with your organizations to get the data from different sources. And the other part I think that we work with our clients is to have integrated platforms. So you cannot be doing measures manually in silos, different data sources, different databases, census data in one hand, in one part and another. So you need to have integrated pipelines to put DCS is one part of that, but you need to collect the data, transform, calculate the measures, and that's just the beginning. And then you need to start pushing the data towards where the action happens, right? Closing the gaps or improving the patient care. So I think it's the full spectrum all the time.
Great. Rebecca, do you have recommendations for organizations that are starting this journey?
Quite a long answer. I have quite a few. You know, I think you heard so much from the panelists, you know, really about how to approach this journey. I think the key recommendation is you just have to take the first step. I agree with what Khanh said. I think even though not many people raise their hands, there's a lot of rumblings we see and we hear in the industry among quality teams that they know that this transition is coming, that they know it's important, that they know that there are real advantages that come from making it, organizational advantages. And I think ultimately, you know, you just have to take the first step and have some faith that there will be people here. You know, there are other people who know more, and you're just going to go find them, and off you go.
Great. And Emily, do you have suggestions or recommendations you would give?
Sure, yeah, I mean, I agree with what Rebecca's saying. I think also just tactically, like finding a few people that are excited about the transition, like find an engineer that like is really excited about the data mapping that needs to be done. Like if you have a few people that are excited about this and then you kind of build a team around them, that kind of, you know, it's another snowball effect. So, you know, just trying to find those sort of early adopters for the transition, and then have them help kind of build the first few wins, and then, you know, you can go from there, and then eventually I think more of the organization will come on side as well.
Great. So we have a few minutes left. I'd like to ask the panelists to just cover any, you know, Khanh, we can start with you. what haven't we covered that you would like to the audience to understand and be informed about?
I think one of the things I want to stress on is we all, as an industry and as a community, we have to lean in, collaborate, experiment, but aim to build a more efficient, a faster, and a low-cost CQL engine. Because if we don't do that, and it's not as good as how accurate our reporting is of quality today, then that doesn't really work, right? The business model there doesn't work. So I think we all have to lean in, we all have to work towards building that low-cost, efficient, high accuracy model, and it has to be at minimum matching with the reporting that we have today. So that's an
You have a technology stack that's reporting today that's not based on CQL. Is it FHIR-based?
We have, I'm seeing my CTO all the way back there. We have FHIR, we have FHIR-based and CQL, and we've actually been reporting on ECDS for many, many years.
Yes.
So we have our pretty sophisticated tech stack in allowing us to participate and also learn, right? Because through this process, we're learning, and how we thought we've aggregated the data and kind of make everything work. Through this process, we thought, okay, here are some areas we can optimize, and through that, we're in kind sharing that information with the digital quality implementers community. So we're all kind of learning through this process together, but I think, you know, we've been able to advance pretty quickly based on the experience that we've already had.
Great. And Rebecca, what last thoughts would you like the audience to know or to learn?
I really liked Khan's. The collaboration here is key. I'll point out another aspect to that collaboration, and that is payer-provider collaboration here, because this does not work without data. And it's really essential that providers and payers, you know, really collaborate to make this possible. I also think that that clinical data, the importance of clinical data, and how valuable it is, not just to this effort, but to many other efforts for a payer, it comes from the top. It starts with a real clinical data strategy. And that is something that can't be isolated just in quality. It has to be across the whole organization.
And Emily, BHI, what would you like the audience to leave with?
I mean, I think it's just, you know, I think there's value in sharing as all organizations are going through this journey. I think each organization will have different kind of hiccups or different opportunities, but the more organizations who are kind of giving that feedback. So forums like this, I think, are just great, and because otherwise it can feel like, oh, every other organization has their really clear strategy, they're ready to go. So just having kind of candid conversations with others across the industry, I think, is one of the big takeaways for me and hopefully others.
And Alan, the journey that Ingenia has gone through, what last experiences that you would like to communicate?
Yeah, I think that we need to embrace the digital transformation. That's the first. It's a mindset, right? Because even for us, yes, we were working with all this HIDIS engine all this time, making updates every year, and now, okay, there is a new normal, and we need to embrace this and start thinking in the vision, right? Because I think we are right now, this year, but in a couple of years, this will be almost a commodity, obviously. There are a lot of challenges to solve, but at some point, you can imagine that we will have, every time that NCQA, CMS, any of the measure steward will publish a new measure, yeah, we won't panic anymore, right? It will be just embedded in the workflow, so that's not your worriness at that point, but you now can focus your resources on analytics, AI. I think Dr. Pearl gave an awesome session this morning. So how to make that data valuable to close gaps or accelerate the timeliness, right, of the impact in the population. So I think for us is just embracing the changes. Obviously, we need to work in parallel because it's a big transition And it doesn't mean that you need to turn off everything you have right now and just start with the new. But yeah, let's create this roadmap, work with the data management team, your specialist team, and set milestones.
Great. So we've got about 5 minutes left. Are there any questions from the audience that you would like this fantastic panel to weigh in on?
Can I ask NCQA a question?
Sure.
Because I didn't see any hands yet. I think the validating of data quality and clinical data is so critical. And so NCQA has the data aggregator validation program. Is it something that you would be exploring or open to validate FHIR outputs?
Validating the quality of FHIR data. Yes, that's definitely something we're looking at. We're trying to figure out, is that going to be part of DAV, or is that a separate initiative? But we understand that in order to do quality measurement, we need high quality data. And assisting the industry to evaluate the quality of their data is something that we're definitely looking at and evaluating. How do we best do that? This drives forward standards. So we're very focused on standards implementations, but we need high quality data as part of that standard.
Great, because I think it's going to be key for this whole digital transformation.
Hi, my name is Jania Fick, and I'm from the Inland Empire Health Plan in Southern California. And this topic, hi, is nice to hear the conversation. And my question is really basic. Could you help us understand sort of the difference? What I picked up from this conversation is FHIR is going to be really important in the future of quality measurement. How does FHIR relate to the other standards of data that we're receiving today? So like the CCDAs and the HL7s, which I'm a little bit more familiar with because that's sort of the data that we receive from our EHR vendors today. Could you help us understand sort of the connection or how does FHIR fit in? And it's a really basic question.
That's a great question. Do you want me to take it, or?
Sure.
We talked about this backstage.
Yes.
I'm like, technical questions, I'm looking at the end.
So HL7 V2 is a standard, but every organization that I've ever seen does it a little bit differently, or extremely different. The V2 mappings that are occurring are all unique to an organization. So the industry has been looking for more standards in order to drive interoperability. It's extremely hard to have V2 messages from one health system, compare them to another health system. There's a lack of consistency. So that's what FHIR is moving towards. Now, Andy mentioned that my son in the opening. Well, FHIR is high school level computer science, okay? It is something called REST, APIs, and JSON. I would imagine everybody here has used REST APIs and JSON today, probably in the last hour on your smartphone. So every website uses that. This is very standards-based technology. It is then a data model, okay? We're standardizing the data model with V2 messages. Some organizations use pipes here versus there, and they put in different information. We're now trying to standardize the data model. We're trying to use one set of value sets. So we're trying to standardize value sets. That's part of FHIR. And then the last part is it's the mandated interoperability exchange method to exchange data. So we're trying to leverage the CMS and ASTP mandates and regulations in order to drive towards a standards-based implementation. In a past life, I actually built a system leveraging V2 feeds, and every organization was very, very different, and it was very cumbersome.
Good evening. Vic Sagi from CVS Health. I'm just curious to understand, we're talking about fire, and I can have the best fire implementation guide that goes against US CDI and have all of that in place. What that still doesn't address is data quality issues that are propagated from the provenance, where it's generated, right? Unlike claims, again, I don't know much about claims to be honest, but on the clinical data, it's messy. It's variegated, right? I can take all the low-income SNOMED codes inside. That's not the system values, but determining if it's inpatient, outpatient, emergency, and the custom codes that we see from the data coming through. How do you address that gap when it's upstream?
There's no perfect solution right now. There's different quality initiatives. We participate in one with the government right now, looking at, for example, the synonym problem. There are, I believe, 57 different SNOMED codes for COVID. And how do you exchange data? Do you have to recognize all 57? But what if you only utilize in your system 3 or 4? What do you do with the other data? So there is no silver bullet. Dirty data is there. We have to identify it. We have to, the industry needs to create tooling around data quality. So, and drive it in that direction.
And I'll make a plug for the DAV program too, because we handle clinical data, so much clinical data, real time coming through our system, from payers, from providers, directly through the EHRs. So we have our NLP solution that also layers on top of that to understand the unstructured and the structured, but even something as simple as blood pressure. When we know how that comes across, it's still very messy. So we have all of our different tools to ensure there's good data quality, and then on top of that, we participate in the NCQA DAV program that validates our entire process from ingestion to transformation.
May I ask a follow-up question on that? Sorry.
Sure.
So does that mean from an audit perspective, making, like NCQA would be more open to making inferences based on the incoming data? Because I know that's a loaded question. When you have custom codes, right, and you have strict audit regulations and stipulations, they don't reconcile as well.
It's a loaded question. It's something we're evaluating because we're seeing that, so, as simple as a measure needing BMI. Well, if you have the pieces, do we allow you to create the calculation? And we're trying to understand what are the needs from the industry. So,
I'm going to make a comment, but I'd like you to respond to it. My name's Linnell James with Blue Cross Blue Shield Association, so I've been working with all 33 of the Blue plans, and I just wanted to clarify, there's HL7V2, there's HL7CDA, and there's HL7 Fast Healthcare Interoperable Resources. It's all HL7. And I think it's important for everybody to understand HL7 Fire is better for making consistent data, but I'd like the group to hear your response.
So I've seen the inconsistencies in V2. CDA is theoretically standardized, but no organization that in my experience, every EHR produces their own flavor or version. So.
I don't know if I can add to that. That was.
I can add to that.
I think,
okay.
well, I'll just,
Rebecca.
Go ahead.
Go first. I mean, I think these are really important questions.
Yeah.
And it's a trade-off between kind of expressiveness and standards. And we get into this situation all the time. Yes. And we can't let it stop us from making progress. We have to pick a point, and we're going to accept that it won't be perfectly expressive, and we're going to just move forward understanding that.
Alan, anything to add?
Yes, I think that versus the previous standards, as you have mentioned, is so important that now this new one relies on already existing established standard like REST APIs or JSON, that's the technical stuff. But the other important part is that the big software vendors like Amazon or Microsoft have created their own fire servers because they rely now on this new standard. So the previous one were so proprietary, maybe, or as you said, different ways to interpret that standard. This one is more plain, right? Is plain and provides for extensibility or maybe customization could be for different use cases. So technically speaking, it is more open and ready to adapt to different cases, not just for quality measures, but for everything in the industry. So I think it's very different in terms of acceptance and growing, right?
Okay, I'm afraid they might be flashing the lights on us in a second. We will be, at least I will be at the pavilion, able to answer and respond to more questions. So I would just like to thank the panel. This has been really a great conversation. Thank you so much.
Thank you.
Good.
If I may, before you leave, a few announcements. We do urge you to go downstairs to the opening reception for the pavilion. That is where you can get your signed copies of Dr. Robbie Pearl's book. Also, you'll notice as you exit, we've erected a tent. That is for the music after dark reception at 7:30. You'll be comfortable and dry, 7:30. See you then. Thanks.
Used to spend my nights out in ballroom. Liquor was the only love I'd known. But you rescued me from reaching for the bottom.